Done.
Ah, no, 12, 20.
Now 8.
Dr. Rajab, you can start now.
Okay, Bismillah, salawat salam wa rasulullah. Welcome everybody to our scientific meetings in the Saudi German Hospital group. This is about this meeting about the head and neck new treatment. And I will introduce my colleagues from different Saudi German hospitals group. Dr. Shawish Adel is a specialist from Algeria, working Saudi German Hospital, Dubai. His scope of service in neck surgery, larynx, and also thyroid. Also, I'm welcoming Dr. Mohammed Abu Saud, oral maxillofacial specialist, Saudi German Hospital Riyadh branch, working since 2011, and his interest in facial trauma and oral and maxillofacial surgery. I'm very pleased to welcome Prof. Mohsen Abu Saud, Prof. Mohsen Abu Hassan, and he's head of department in Cairo branch, and he has a long experience, about 11 years experience in Asir branch, and he's also working with our main speaker today, Prof. Max. Finally, I'm very pleased to welcome and introduce our guest today, and is our speaker, Prof. Dr. Max Peter Harlan from Germany. Is our maxillofacial surgeon and head of department in Charité Hospital. He's qualified in oral maxillofacial surgery and PhD in oral and maxillofacial surgery since 2004. Has very long experience, about 25 years in the field, and he was previously the head of department of oral and maxillofacial surgery in and the medical center of Hamburg, Eppendorf. And as I said before, he's now the head of department in Berlin, Charité Center. Welcome, Prof. Max, and the floor for you now, and we are listening to you. Please.
Dear Dr. Al-Sarani, thank you very much for the nice introduction. Dear colleagues, dear friends, it's my pleasure to join this evening the news about the treatment of head and neck cancer patients. And I hope after the lecture you will get some new input for your care of your patients tomorrow morning. Let's have a look how it proceeds. Okay. Oh, why is not... Ah, here. Still, the oral squamous cell carcinoma and the head and neck cancer is one of the 10 most frequent malignancies worldwide. We have about 300,000 new cases per year to treat. And what's new in this? First, the 8th edition of the TNM classification, especially regarding head and neck cancer, had some modifications in the classification of our tumors. And there are 2 points that are especially relevant for us. This is the modification of T stages of the oral carcinoma and the modification of the N stages of non-viral associated head and neck cancers. Why? Let's look in detail at the T stages. For the T stages now, we have also the depth of invasion to be considered, whether we have a T1, T2, or T3 cancer. And this has therapeutic consequences for our patients. Meaning, and the invasion depth is not related to the tumor's thickness itself. We always measure this from the basal membrane. So it's a diagnostic or a judgment from our pathologist, what is the depth of invasion of our specific tumor. And this in millimeters affects the T classification of these cancers. So from the clinical point of view, if you have an exophytic tumor, it can be a complete different impression what is then measured histopathologic. The modification of N stages of non-viral associated head and neck cancers now considers the extracapsular spread. And this can be microscopic or major. So this has also now influence regarding the N stage of our patients. Let's look in detail what this means. This means if we have a T1 or T2 tumor with an invasion depth of more than 1 centimeter, this is now classified as a T3 cancer. And this has a consequence for our patient because in the T3, we would recommend adjuvant radiotherapy. On the other side, if we have one ipsilateral metastasis smaller than 3 centimeters with extracapsular spread, this is now classified as a N2A. So, and this means this patient will undergo radiochemotherapy or radiotherapy. So this means we, in this specific circumstances, we have some kind of upgrading of our patients and being more aggressive due to the new classification of the TNM stages. This is relevant in everyday treatment of our patients. Still, and this is like starting and end of the lecture, the therapy of first choice in patients with oral squamous cell carcinoma is still surgery. And this means, in my experience, with a safety margin of at least 1.5 centimeters in all dimensions. We had a huge discussion in Germany with our oncologist whether resectable HPV-positive oropharyngeal carcinoma will be treated by primary radiochemo in future and not be treated by surgery anymore. This was like a pro and cons debate on the cancer conference 2 years ago. But this is still not true, although in the literature you might get the impression. In our debate, let's say the summary was that surgery, even in HPV-positive patients, is still a central part for the individual treatment. And at the end, only the surgeon himself can decide whether a tumor is resectable or not. If you look at the literature whether surgery was included in the therapy, the patients with surgery have better prognosis instead of the patients without surgery. In my opinion, in many patients, function and quality of life is superior when surgery was part of the treatment. You have to be very careful what is HPV positivity means, because P16 is not a valid marker itself. And if you look at the lifetime cost of patient treatment, if you include surgery, the cost might be lower. What about the new substances, the immunotherapy that's in the market and is spread in all tumor entities? And the most experience in the head and neck we have with nivolumab. The nivolumab was in November 2016 approved by the FDA for recurrent, progressive, or metastasized head and neck cancer after previous chemotherapy with platinum. In March 2017, we got the same approval in Germany. And with this, let's say so, the story starts. And based for this approval for the FDA was this New England Journal paper for the recurrent squamous cell carcinoma patients. And here we see an increase of overall survival from 5.1 months without nivolumab to 7.5 months with nivolumab. So this is not a dramatic improvement, but it was statistically significant and led to the approval by FDA. So what is the situation nowadays? So what is the current role of immunotherapy in our patients at the moment? First, if we have the recurrent or metastasized situation, nivolumab and pembrolizumab are included in first-line and second-line chemotherapies. However, what is in primary and curative settings, here we have multiple ongoing studies in combination with radiotherapy as an adjuvant therapy or even as a neoadjuvant approach. So we have to test in which situation patient will really benefit. Let's look, for example, for the palliative setting at the Keynote 48 study. And here there were 3 lines. We had pembrolizumab as a single treatment. We have pembrolizumab plus chemo, or we have the gold standard of the extreme study. And if we look at the results, what's going on? Yep. If we look at the results, in terms of the overall survival, pembrolizumab versus the extreme, you see that we have a significant better survival in comparison to the gold standard. And even if we combine pembrolizumab with chemo versus the gold standard, it further increases. However, not all patients benefit from this. So if we look at a little bit more in detail, we have to look at the immunoscores of the patients, and patients who do not have a positive score, they do not benefit from checkpoint inhibitors to be included in their therapy. So we have to really differentiate our patients, whether pembrolizumab or any other kind of immunotherapy would be beneficial to them. And in more or less in the oral cavity, we consider 25% of our patients to be good candidates for immunotherapy. And if so, they really do benefit. But here we are in the palliative setting, not primary treatment. So if we have positive patients from the immunoscore, they would benefit. And now in ongoing studies, we are trying to use the checkpoint inhibitors earlier in their treatment. And the story goes on. We have already the second generation of checkpoint inhibitors in the line. So there will be multiple new drugs coming into the market, and we of course have to evaluate them regarding our head and neck cancer patients. And I want to show you or share with you one very impressive case. I was really personally involved, and I really was deeply impressed. This patient was presented to me, I think last year when he was 58 years old. He was a smoker, had recurrent tumor bleedings. His medical history started in September 2013 when he had a squamous cell carcinoma of his left mandible. This was resected. He got postoperative radiochemo, 2013, okay? We had a PT4A PN2B stage. He got a recurrence in March 2017. He was re-radiated plus 5 cycles of cetuximab. He got in this July 2017 a squamous cell carcinoma on the opposite mandible. As you can see on the CT scan, you see on the beside the mandible the tumor metastasis, and he was considered to be palliative then. So starting August 2017, there was palliative chemo, 6 cycles of extreme, that is the gold standard, was given. In February 2018, the patient progressed. Then he was included in the CRO study with pembrolizumab, but however, in August 2018, he was excluded because he progressed. Then they were starting with nivolumab, and in March 2019, he was included in a phase 1 study with a very specific agonist. Then he was presenting to us because he was presenting with severe recurrent tumor bleeding. So we did embolization with our radiologist of left lingual artery, right lingual artery, again right, again left, and at the end, the right external carotid artery was embolized in July 2019. This was the situation of the patient. And so we were faced with the situation of how to proceed with this patient. And at the end, we said, okay, well, let's get rid of the mass that is there to stop the bleeding and cover the whole defect. However, in a neck like this, with re-radiation, embolization of multiple arteries, it's not so easy to find vessels for anastomosis. But we proceeded and we covered it, everything with a huge soft tissue free flap. This is 2 weeks after surgery. And in the histopathology, there was no tumor found. Unbelievable. 58-year-old patients on a palliative setting. Every therapy that was available was given, and then he was included in a phase 1, a very experimental study, and the tumor was killed. This was really impressing me, and I'm really skeptic whether I'm, as a surgeon, will treat cancer until the rest of my life by surgery. But at the moment, surgery is still the gold standard. So, and again, we have a safety margin of at least 1.5 centimeters, in my opinion. So what does this, from the surgical point of view nowadays, mean to our patients? And we, of course, if we create defects in these dimensions, we have to reconstruct the defects and cover the defects. And for this, microsurgical free flaps are the therapy of choice. And as you can see here, when I was former in Hamburg, and the same is in Berlin now, we use them quite often, and we use a variety of different free flaps. And however, because our patients are getting older and older, we always have the question in older patients, do we need or do we have to undergo this big kind of surgery, or can we do it a little bit easier? And we looked at our patients, and in this study, we had 34 patients included that were older than 80. And they were doing the same. It takes a little bit longer, but age by itself is not a risk factor for free flaps. We have other factors, length of ICU. We have, if a patient has radiotherapy before or needs more than one free flap, we have risk factors. But age itself is not a risk factor. So most of our cancers are around the mandible. So if we have to a segmental defect of the mandible, how to reconstruct this defect? However, we have to look at the remaining mandible. What is the height, the shape of the area of our bony defect, the extension of the soft tissue needed, and do we have pathologies in the lower leg? And in most of our patients, we go for the fibula free flap because this is really our working horse. We can work in two teams in parallel, and we can nearly create everything suitable for mandibular defects with this transplant. And the donor site is acceptable regarding the morbidity. So free flaps of the fibula we use especially in segmental defects of the mandible. We can use it even if we have severe atrophy for, let's say, dental rehabilitation. We can use it even for segmental defects of the long bones, and very specific in necrosis of the femoral head. This was a gentleman years ago treated when I was in Hamburg, when I was a resident. And with this, I can show you the development and the improvement we have achieved. So this was his X-ray, and this was an ameloblastoma, and it was resected, as you can see here. And this was the fibula free flap harvested by Dr. Lee by this time. Not much muscle around, just the bone and the vascular pedicle. You can do so, but you can leave a little bit more muscle around. This was the X-ray, and of course, the shape was not like a mandible. So we started with a distraction in the anterior area to get a widening. And you can create nice bone like a callus in the when you use distraction osteogenesis in free flaps. Then we continued with a distraction on the lateral aspects to get more projection anteriorly. You see these huge gaps. And here you have bone growing again. Then you can continue with dental rehabilitation with implants. And then you get the prosthesis done intraorally. And at the end, you have the final prosthesis. Your patient is rehabilitated, and that's what we aim for even in malignant tumor patients. And patient was fine. However, we needed multiple steps to achieve this result. It was not done in big step. So nowadays, we are really planning our procedures in advance on the computer in 3 dimensions to really adapt the transplant we are harvesting to the defect we are creating. And this means that we need DICOM data from the harvesting side, from the donor side and the recipient side. We need some kind of interactive planning, and we need a resection using individual guides and the fixation with an individual implant. So when we have this virtual planning done on the computer, we have to transfer this to the OR. And this can be done by guides. This can be done by robots or augmented reality or by navigation or with implants. And as said before, we use intraoperative guides and implants. And then at the end, it's really like a puzzle. As you can see here with this kind of implants, the double barrel fibula in the front, you can really have like a 3-dimensional reconstruction what you want to achieve. The question is how much stability is needed, because if the free flap is living, you can really just mini plates and screws, or you use a big recon plate, and there's not much evidence what is really needed. And if you know, if the patient is undergoing radiotherapy afterwards and you have a big plate in place, you can get a lot of trouble regarding the soft tissue envelope. So nowadays we are usually using 2.0 locking plates, and these are produced as CAD/CAM plates, very individual. We looked from the biomechanical point of view, and we saw that with this 2.0 plates, we are on the safe side, and not the plate is breaking in these experiments, but the screws are breaking. You know, if you do a recon with a recon plate and you have a segmental defect without a bone, usually the plate breaks in the angle area. The CAD/CAM plates, no, because they are not hand bended, not weakened by the surgeon. In these patients, really the screws are breaking. And here's another example to give you a comparison to the guy with the ameloblastoma. This patient had an osteosarcoma and the left canine region of the mandible. And this was the initial resection. It was positive on both margins, so it was proceeded. And at the end, she ended up with a big recon plate and a latissimus soft tissue free flap and was asking for mandibular bony reconstruction. Then when I met the patient, and here we started really on the computer. Of course, you can do a 5-segment fibula freehand, but it's very difficult. Remember the guy with the ameloblastoma. So here it's really beneficial to play on the computer and to transfer this by a guide for harvesting, as you can see here, and you can work parallel in 2 teams. Here you have the guide for harvesting the fibula with 5 segments and a small skin island. And here you can really fix and create the new mandible while the transplant is still on the lower leg under perfusion to reduce time of ischemia. And when the head and neck work is done, you transfer everything like a piece of a puzzle to the mandible defect. And here you see the virtual planning and the postoperative cone beam scan. Patient during follow-up, implants already in place. Patient now, I think, around 18 months without recurrence, and the intraoral rehabilitation going on. And the soft tissue is a little bit reduced. Another example, as we do today, we have a squamous cell carcinoma of the floor of the mouth. We go for virtual planning, resection of the chin, just anterior of the mental foramen, harvesting a double barrel fibula with a huge gap to flip one segment on top of the other. And here you see, we start with the tracheostomy, we make a bilateral neck dissection, the guide for resection of the bone in place, the mental nerve on both sides exposed and freed. And parallel, the second team is harvesting the transplant just of a bony and muscle component and the vascular pedicle. And here you just, the lower plate is the CAD-CAM plate, the upper plate was, the mini plates were hand banded and intraorally left for secondary healing. And here the patient 1 year follow-up, just wait and see. The mini plates have been taken out, the intraoral situation with implants, just wait and see, nothing, no grafting on the muscle cuff, and then you can start with the prosthetics later on, and patient rehabilitated very fine. That's the way of life quality after surgery we are always trying to achieve. So we did a lot of CAD-CAM cases in Hamburg, and we continued like this in Berlin, and whatever company you choose as partner, whether it's Depusynthesis, Kalos Martin, or smaller companies like Planmeca, it's working. And it's working and it's accurate. And we are so convinced that we are just at this time, we are establishing a 3D lab for printing in public-private partnership with Kalos Martin. And this is the photo from last week, how the situation is. And we really bring the facilities in our hospital to produce them on site. The question is, however, when to reconstruct the bony defect. As mentioned before, I'm a fan that we do it at the same time as we resect the tumor. So this is called like a primary resection, reconstruction. So because in most of our mandibular tumor cases, we get a segmental continuity defect. Without bridging, it's not adequate. So we have to do anything. On the other side, the most relevant factor for prognosis of our patients is the resection with safety margins. And of course, for the bone, we cannot get frozen sections. However, if we reconstruct on the same site, at the same time point, probably our transplant will undergo radiotherapy as well. So it is still a pros and cons, but we aim for that we have one big surgery and everything is done. Immediate reconstruction versus secondary reconstruction. So we want to avoid an additional surgery with risk and costs. Of course, then it would take more time. The operation side will be more difficult, especially after radiotherapy. And secondary microsurgery might have a higher complication rate. And on the other side, we have the risk of the bony margins. So, but on the other side, to see patients for secondary reconstruction like this in Germany, we don't want to see this kind of patients anymore. This is not adequate. This, of course, is a very difficult situation to improve. She has a tracheostomy for the rest of her life and asking for rehabilitation. So we're trying to rebuild her mandible, but on the computer, everything is very easy. In reality, it's not so easy. And of course, we need a huge soft tissue envelope to cover everything in the chin area. Here you see after 7 days, so it's getting better, but not back to normal. On the other hand, even with the DCIA and the lateral aspects, you can do it everything on the same time. Because of these printed guides, the transplant shape is exactly fitting your defect site. As you can see here, whether you do it in 2 teams or in a single team, it's just putting in the transplant into the defect, and that's it. Patient 9 months post-operatively, you can leave the plate in place if it's not in the way for your dental rehabilitation, and that's it. And that's how we want. So is it immediately reconstruction safe from the oncological point of view? Because of the bony margins, we have some area of unsureness. So we looked at our own patients. We looked at 21 patients that we did immediate bony reconstruction. We had a follow-up of at least 1.5 years. And the survival rates and the rates of recurrence were in comparison to the literature. So from the oncological point of view, it's safe to make the bony reconstruction on the same time. So in cases of oral squamous cell carcinoma, nowadays, from our point of view, we make our planning virtually 3-dimensionally. If we have bony involvement, we make the resection with the guides. We reconstruct the bone immediately. Then we decide whether we go for adjuvant radiotherapy or radiochemo, and then the patient is under follow-up, including the dental rehabilitation. So, and nowadays, as you know, all our patients will discuss before therapy and after therapy in interdisciplinary tumor boards, but is this also beneficial to our patients? So we looked at a tumor board study group and a historical control group without these interdisciplinary discussions. And we looked at the oncological parameters in both groups. And we included in total 321 patients in total. And we see that in the tumor board group, we operate the same level of patients. We do not lose patients to non-surgical treatments by these discussions. But from the adjuvant point of view, patients are significantly less undergoing radiotherapy. So we objectively clarify whether a patient will really benefit from adjuvant therapy. It's not more the feeling of the surgeon. We really look at the clear data of the patients. So, and furthermore, we had overall survival rate of the study group that was a little bit better than in the control group. And so the tumor boards are really beneficial to our patients. However, in my personal opinion, I believe that in certain patients, we can reduce our surgical aggressiveness. And these patients mean if we have a clinical and radiological N0 situation. And in this, I'm a big fan of the Sentinel lymph node biopsy instead of the elective neck dissection. This is standard in breast cancer and melanoma. And it's in the literature since 20 years for head and neck cancer, but it was not really sufficiently working because of technical issues. And on the other side, if we do elective neck dissection in an N0 neck, we find metastasis only in 20 to 30%. That means on the other side, 70 to 80 patients are overtreated. And this is my motivation to include this technique as an additional, let's say, staging maneuver. And if you look at the literature, there are many papers out, but because randomized control studies in comparison to elective neck dissection as a standard are still missing, even in Germany in the guideline, it is not included. It is just recommended inside ongoing studies, not besides. In the other European countries like UK, Spain, or the Dutch, it's different, but in Germany, it's not included. However, we do it in our department, and we started in April 2018, and up to now, we have at least 28 patients with a sufficient follow-up, and we included every patient we consider to be beneficial: oral squamous cell carcinoma with N0, squamous cell carcinoma of the facial skin, malignant melanoma, Merkel cell carcinoma. And we used this lymphoseq in favor. This is a really nice drug. And our workflow is, as you can see in this patient, he had a cutaneous tumor on the cheek that he gets an injection the day before surgery. And then we get the scanning by the nuclear medicine. And we see the first lymph nodes that as a sentinel immediately during this imaging. And on the next day, we do the surgery. And during surgery, we have like a probe that's identifying the really individual lymph node that is the sentinel. And this is not always the big lymph node you observe. It can be a very, very small lymph node just beside the big one. And you really identify which one is the draining one, and you can give your pathologist a hint at which lymph node he has to look in detail, mainly probably with immunohistochemistry. So I'm really a fan of sentinels to do less neck dissection in patients with N0 necks. However, if you treat patients like this, sometimes your treatment of the complications is much more demanding than the original cancer treatment. And a patient like this with an extended osteoradionecrosis was not treated in my department before, but came to me for secondary reconstruction. And of course, we would agree that in this situation, we can't leave it as it is because it was smelling as it looked like. So life quality was really bad, although the cancer was gone. And the fibula was not possible due to vascular situation of the lower leg. Then we started to use a scapula free flap and including a TMJ prosthesis from both sides in one piece. And this is really, we reconstructed a piece of the mandible and the rest was artificial. And surgery like this in a neck like this is really hard work. But if you have a free flap experience due to the primary cases, you get also some experience with the complicated secondary cases. And at the end, it was, we took out the nerve, we created the preauricular bed for the TMJ prosthesis, bilateral. And I think it was close to midnight when we finished the case. This was the postoperative cone beam, acceptable. And if the patient was staying in our hospital for weeks because he developed all the complications you can dream of. Pneumonia, heart failure, kidney failure. He got a pacemaker, stents, angiographies. So really everything he took. And I was confronted with his face for many, many weeks during my rounds in the morning. Here you see him 6 weeks after surgery. Alhamdulillah, everything was still covered intra and extraorally, because if this implant is exposed, you have to remove everything. Sometimes reconstruction of facial structures in cancer cases needs more than just surgery, and you have to keep it in mind that not everything can be solved by surgical techniques, especially from the aesthetic point of view. And if you look here at a patient like this with a defect like this, of course you can close the defect by surgery, but what about the aesthetic result then? So in these cases, we consider really that we need some anaplastologist with us and to play around. And the job of the surgeon is then more to give good retention for everything, but instead of closing the defect. And sometimes the anaplastologist really ask us to make the defect larger, that they have more space to work on. As you can see here in this case, you see it's nicely rehabilitated with an extraoral and intraoral piece that are attached together by magnetics. Another patient, another example, similar defect, extra and intraoral situation, especially the nose. If you want to reconstruct it, maybe with a forehead flap, yes, you can close it, but how it will look like from the aesthetics. And especially this gentleman was really concerned about the fixation, the retention of the prosthesis, because he was an active gentleman and he doesn't want to lose it while he's driving his motorcycle. However, even in our departments, there are cases that are really our limits or beyond our limits. This was a patient admitted in Hamburg to our hospital with a history of 15 years of growing, blind on both eyes, severe pain. And in these cases, it's really beneficial for all of us to discuss these options we have. It was a time before the immunotherapy, to be honest, what to do. Because sure, we cannot heal, we cannot remove the cancer in total, but the pain was so severe and the eyes were without any function. In the tumor conference, we really decided to make it as a tumor reduction in a palliative approach. And in this, we used navigation not to lose our orientation. It was really a resection of the complete face, including as much cancer as we can. And then we put in some retention elements to really get some retention to the anaplasmatologist later on. Of course, we included a huge free flap to cover all the structures, the skull base and the midfacial volume. Here you see the postoperative result. Of course, blind as before, no question. And then the anaplasmatologist really started to build up an artificial face for him, just for his social interacting when the nurses and the family was visiting him. Of course, these cases are really the limits, and you really have to decide very individual whether surgery is beneficial for the patient or not. With this as a take-home message, we have new possibilities for our patients in terms of staging, how to address the individual risk of our patients regarding especially non-surgical treatment options with the immunotherapy. Surgery itself gets more individual, better planned, and of course, in some instances, maybe de-escalating, because we do not have to remove all the lymph nodes in the neck if there's no metastasis. And surgery will still play a key part of the treatment protocol, but however, in future, maybe our position will get a little bit weaker, depending especially on the new immunotherapy approaches. And with this, I want to invite all of you to visit me in Berlin and to look at our tables, how we are doing this kind of surgeries. You're very welcome when Corona is over to visit Berlin. Just send me an email. And with this, thank you very much for your kind attention.
Thank you so much, Prof. Max, for this very interesting cases. I'm really getting excited to work late at night. This very nice cases. Actually, I'll start by Prof. Mohsen. If you have any addition, Prof. Mohsen, or comments in 2 minutes, Prof. Mohsen, if you don't mind.
Thank you, Dr. Rajab. Thank you, Professor Max, for this excellent, valuable presentation and very difficult cases, really. I have one question regarding the reconstruction of the mandible, especially in case of small or partial resection of the mandible. We know, as published many cases before in the literature regarding the destruction osteogenesis by segmental or disc transfer to reconstruct the defect, especially if partially resected mandible. What's your opinion, Professor Max, regarding this reconstruction by the destruction osteogenesis?
Yeah, Dr. Mohsen, thank you very much for the nice question. There are 2 points to consider. First, is radiotherapy needed or not? Because if you have a radiated area, especially the soft tissues and the bone quality will be affected. Second point is, if you have a defect created by surgery, you should consider just a soft tissue flap to have enough tissue around your bony socket to use during your distraction, that the bone is still good covered and you have enough tissue around. I'm a big fan of distraction osteogenesis if you have remaining bone of good quality and the soft tissue envelope is also sufficient that the bone can grow into the pocket. And after radiotherapy, I would be a little bit more skeptic.
Okay. Thank you, Professor Max.
The second panelist from our tonight is Dr. Shaush Adil. If you have any comment or question.
Okay, first, thank you very much, Dr. Rajab. Thank you very much, Dr. Max, for this excellent presentation. I don't know if you can tell us more about your experience about using the 3D printing biomaterial in mandibular reconstruction.
Honestly, the 3D printing at the moment is for the guides and for the guides for resection and the guides for harvesting the free flap. Then we get a 3D printed titanium.
Dr. Shaush, if you don't mind, Dr. Shaush, to mute your microphone.
Then you get a 3D printed titanium plate that looks like a normal reconstruction plate, but is exactly in the shape that you need. And in the guides, in the white guides that are used for the resection and the harvesting, you have all the drill holes that you pre-drill at this stage that will fit to the individual printed titanium plate that you will use for fixation. That means the shape and the dimension of the reconstruction is exactly what you decide on the computer. However, it is at the moment for the big defects not possible to use something printed or 3D printed to close the defect, to bridge the defect. You still need some kind of tissue inside, like bone transplant or whatever. It's not possible to use it everything from the 3D printer because the volume, the distances are too big. It will not survive.
Okay, thank you very much. Thank you very much.
Our third panelist, Dr. Mohammed Abu Saud, if you have any comment or question, please, for Prof. Max.
Yes, greeting, Dr. Max. I have one question regarding the current guidelines for extent neck dissection in oropharyngeal and tongue cancer. Is level 1B, the submandibular triangular, is enough and mandatory for the tongue cancer and the oropharyngeal cancer?
That's a very good question. Greetings, Mohammed. It's usually the classic routine way. If we have an N0 neck in the staging, meaning we have no signs of metastasis, then we would always go for level 1, 2, 3 as an elective selective neck dissection, level 1, 2, 3. If we have metastasis in the staging, in the CT scan, that we will probably go for level 1 to 5 in a modified radical neck dissection. And regarding these N0 necks, what I try to show is that I'm really a fan of these sentinel lymph node diagnostics, that we take out only the relevant lymph nodes and not all of them in the level 1 to 3.
Yeah, thank you so much.
Thank you so much. I have a comment, Prof. Max, before we go to some of the audience. They exceeded 515 audience, which is huge. Thank you so much for the interesting the subject and also a very interesting lecture. Actually, I have a comment about the N0 patient in our own patient. Yeah. Actually, yes, the occults in Germany are part of the world is 20 to 30%. Actually, what we found in our local patients that more than that, 50% of the patients they have high occults. Yeah. So we tend to be more liberal to do elective neck dissection actually. And as you say, from our neck dissection, especially up to 2A, most of the time, especially in the oral cavity cancer, especially tongue cancer, we are doing supraomoid neck dissection, including 2 from, as you said, supraomoid neck dissection, and we found actually very high numbers of the high occult. To be honest, we have a lot of studies, but we don't know till now what's the cause exactly why our patient or our disease is more aggressive in this part of the world, especially in the south of Saudi Arabia and Yemen. But I think it's related to some of the substances that show it, or like the or something. And I think this is why it's increased, as you mentioned, Prof, in the new classifications of the head and neck. Even in non-smoker patients, the human papillomavirus play a role. So do you have an experience of another patient came to the ward? Because I trained in Germany actually, and I saw many patients came from India, or at least originally he's not from Europe. Do you have, as you said, you are a fan of the sentinel lymph node to avoid unnecessary selective operations, which is actually it will be very complication, and even it's preclude sometimes the reconstruction times and your facility in the reconstruction.
Yeah, we are still a little bit careful about this because we don't want to risk the prognosis of our patients. So we want still to be on the very, very safe side. But as you know, we have to include from the guidelines a pan-endoscopy examination in our staging procedure. And this is usually done under general anesthesia. And we are trying to include the sentinel lymph node at this maneuver under general anesthesia, meaning we make a sentinel lymph node biopsy together with the pan-endoscopy, that we have the information of the sentinels towards our final surgical treatment. This is the way we are thinking. But I totally agree with you. There are patients that will really be very risky to not do the classical neck dissection. It's really under discussion. It's not a gold standard at the moment. Definitely no.
Perfect. So actually the same practice.
Yeah.
But we are doing this, the standard care of management usually with most of the patients, and it's an individualized. The head and neck now is individualized for the patient. Exactly. I have two questions. One of the questions here, it's about the chemotherapy and immunotherapy in your practice or in your experience.
So first of all, if the primary tumor is resectable, our first recommendation to the patients is to go for surgery. This is still the gold standard. And for us, the chemotherapy and the immunotherapy comes to mind when we go for adjuvant therapy. At the moment, we have an ongoing study, the so-called at-risk study, that we have patients that need adjuvant radiochemo, for example, because of extracapsular spread. And there are two arms. One will get radiotherapy with chemo, and the other one will get radiotherapy, chemo, and immunotherapy additionally. And this, I think, makes very much sense. What we are not at the moment have is something, if we have an HPV-positive patients with a good prognosis, to do some kind of de-escalating. At the moment, we treat everyone the same. And we are still playing a little bit around which let's say, combination of therapy for which patient will be the best. At the moment, we really do not know. The development of new drugs is too fast at the moment to adapt it really to the single patients. What I like from my idea is to look at the immunotherapy before surgery, neoadjuvant, that you make some, let's say, 3 dosages, and you look whether he will respond or not. And if he's responding, you can continue with a non-surgical approach. If he's not responding, you stop it and you say, go for surgery. But this is also still under study. It's not.
This is, and yeah, good, perfect. This is in the advanced stage of oral cavity cancer.
Yeah. The simple
and what's
one, the simple ones go for surgery.
True. Actually, I have a review about the advanced oral cavity cancer. I'll send the study to you to have your opinions here. What's the response parameter or criteria that you depend on either to complete that arm of the intervention in terms of new adjuvant, or to stop it at that point and to start resection? What's the criteria that we depend on?
In the neoadjuvant setting, I have no personal experience because we are not taking part personally in the study at the moment. I've seen patients when we, let's say, in a recurrent difficult situation, and we started with immunotherapy, we see some kind of progression because of the immunoreaction of the patients. And we are skeptical whether the tumor will explode, but at the end, it's only the immunoreaction of the patients. And so you really have to continue with the treatment, and then you see like a dramatic shrinkage of the tumor. But initially, the tumor expands and looks bigger, and you think, oh God, what's going on? And then the response comes. So it's really, even from the clinical point of view, it is, let's say, new for us. What is important is that you let your pathologist look at the expression of the relevant receptors for the immunotherapist. If the receptors, there are different, let's say, codes or different scores, and you have to define with your pathologist which to use. And if the score is adequate for immunotherapy, then the patient probably will benefit. But if there's no positivity in the score, there's no benefit. Then you don't have to try it.
Perfect. Actually, Prof, there is one question, but I think it's not formulated well because of the mistake in the staging. What's the prognosis? What are the prognosis of parotid salivary gland tumors T3 and 2, M2? It should not be because there is no M2. Anyway, the advanced stage of parotid tumor from your experience, what's the prognosis? I did not mention which type of parotid tumor, but I'll ask you myself a question. The high-grade parotid tumors, in your experience, what's the prognosis and your personal experience?
So parotid cancers can be very bad if the initial treatment is not successful, or the tumor is very big and very large. Then the prognosis can be really bad. And of course, the morbidity of treatment in terms of surgery, radiotherapy, regarding facial paralysis, mouth opening. So the patient really suffer a lot. So salivary gland tumors, especially of the parotid region, if they have an advanced stage, are really bad for the patient. And there's nothing really to solve this problem. It's really bad prognosis and bad life quality, and even for the surgeons, not easy. But at the end, the same surgery if possible, adjuvant treatment. So the rules are still the same. There's no change.
I'll add to that your great experience in my later experience. I'm not that experienced like you, Prof. But actually, I'll add again. Yes, it is the if it goes wrong, these parotid gland tumors, even the low grade, if you did not tackle it from the beginning with the very good surgical treatment, I think it's a nightmare for everyone, for the patient, for the surgeon, for the institute. So I think with the specific, we used to say that the minor salivary gland and the small gland is carrying poor prognosis. I can assure you that the parotid, if it's with high grade and it's not treated well, it's even worse than the minor salivary gland. I haven't. Are you agree, Prof? Do you have any comment?
Even with benign tumors, it can be a nightmare if it's not treating adequate at the first set. If it's opened and it's spread, it could be like not good. Sure,
even the leomorphic especially in the deep loop, or if it's not treated well, it's very difficult to treat actually because of the seeding of the tumors, and it's multiple, and even, no one can help you, even the radiation therapy. Sometimes, yeah, Prof.
Hello?
With the big epicenter, the leomorphic adenomas, I used to ask my colleagues from the radiation therapy to help me, and some of them they have very low threshold to help me in that. Do you agree that some of the benign tumor in parotid can be helped in the radiation?
Yes, in very selected cases, in difficult situations, when probably if you have a multiple recurrence, then it can be helpful, yes.
Okay. What's your experience, Prof, in the minor salivary gland originating from the base of the tongue, especially base of the tongue or the oral cavity? Do you have any experience about the treatment of the minor salivary gland intraorally?
The treatment principles are the same, but the prognosis of malignant tumor in the small salivary glands seems to be even worse. And but the treatment protocols and the treatment principles are the same as for a squamous cell carcinoma. Resection, if possible, with safety margins, reconstruction, and adjuvant therapy. And tongue base can be a complete nightmare, because if it's crossing the midline, then you're talking about a glossectomy, and this is something really, you have to really judge whether the prognosis is worth to do it.
Aspiration and the other things. The last question, sir, I want to ask about one of my cases that he present to me a recurrent giant cell tumor in the mandible with very big, Actually, when you take a biopsy, then there is another rare disease, cancerous sarcoma of the mandible.
Okay.
Yeah, and actually we did the surgery, total mandibulectomy and neck dissection. Actually, it's not radiologically apparent, but actually it was positive. It's more than 3 lymph node positive, more than 2 centimeters. And actually, we delay the reconstruction. Do you have cases that giant cell transfer to be a tumor?
Was he radiated?
No, he's not radiated. Actually, the first surgery, it was in one of the big center, even the big center, and very well-respected centers from our colleague, the maxillofacial. And he presented to me, actually, I'm very fan and colleagues of all maxillofacial. I'm work with them in one team. So no, not irradiated, but the question, is it really true diagnosis? Do you have any cases like this? Transfer to cancerous sarcoma?
I don't remember a personal case like this. And always when this happens, I have a doubt whether the first biopsy was in the correct place or was representative for the whole lesion. That's why I'm always concerned then. I have no case like this, I'm sorry. But in sarcoma, the treatment is completely even more difficult. And in sarcoma, we regularly delay the reconstruction. That's true even for us. Yes, I totally agree with you.
Perfect. That's why we decide, sir, to delay the reconstruction, because we want to know that oncologically safe. We are really taking the whole tumor and there is no remnant and the negative margin. That's why we decide to delay. And I'll be happy to send it to you through email. So I'll ask your experience if you have any advices about that patient.
Do so.
Actually, we conclude this very nice webinar with you, Prof. I'm very delighted and grateful to you and to our colleagues, Dr. Shawsh Adil, Prof. Mohsen Abu Hassan, and also Dr. Muhammad Abu Saud. Thank you so much for the Saudi German Hospital Group to make the scientific continuous medical educations valuable and also very enjoyable, especially with the distinguished speakers like Prof. Max. Thank you so much for the audience, and hoping to see you next time in very interesting lecture and academic activity. Thank you so much to everyone.
My pleasure. Thank you. Bye-bye.
So much. Bye-bye.